there are certain terminologies like preterm, late preterm, early preterm, very preterm, and all these things are there. So the understanding because we go forward, they may not say when will you terminate, and all these things are there. So is there any exact difference by definition of age groups?
So basically when you say this 37 weeks, it is actually 259 days. Okay, so that's another way of looking at it. Now, as Aswath was asking about the classification, the CDC has actually given a classification for that. And we know preterm is less than 37 weeks. There's something called early and late. So when you say the early, it is between 32 and 34. Okay, that's easy to remember. Between 34 and 36 or 37, no, what we said, that is the late. So the cutoff is 32, 34 and 34, 37. So that is early and late. Then there is another one more, which is called very preterm and extreme preterm. So always remember E comes last. So less than 28 weeks, we call it as extreme preterm. And there is also a very preterm between 28 and 32. So when I put everything together, extreme is below 28 weeks. The very preterm is between 28 and 32 weeks. The early preterm is between 32 and 34 weeks. And between 34 and 37 weeks is actually the late preterm. Okay.
See, madam, we told it's a common problem, preterm labor. How common it is? Or what is the problem in India or the world about this prematurity and preterm labor?
Yeah. I'll just tell you one thing for all of you who all are listening. Through my entire experience, I've realized that in the days that I started doing practice and today, the commonest admission to the NICU is actually prematurity. That has not changed. So really, have we contributed much to the management? I do not know. WHO has estimated the problem of prematurity. They say about 15 million babies are born preterm per year. That is not enough. And India tops the list. That is the thing. India tops the list and of preterm neonatal births. And that is what is very, very alarming. And so we will put our preterm birth at a rate of about 15%. Okay, about 15%. And if you are to say that in the form of births per year, we say that because of prematurity, about 3 lakh neonates die per year in India. So it is a very big cause for mortality also.
Neonatal and mortality also.
Mortality is also. That is the biggest problem. So as I told you all, it is the commonest admission to NICU.
Usually we say that in the neonatology say that if there are 10 NNDs, if you ask the neonatologist, more than 50% of them will be preterm babies. So that is the enormity of the problem we have. See, madam, we feel that your experience for last many years, 35, 40 years, you feel that the problem is increasing or decreasing, this problem of preterm labor, and why? What is your take on it?
Yeah, that's a very good question actually, because it is on the increase, unfortunately. And I would put it across as due to the ART. ART is really responsible because they say about 7 to 10% increase in prematurity has been because of ART. And because of ART and the multiple pregnancies. So that has been the main contributing factors why it has increased so much. And there are also certain specific areas. I told you India tops the list, you know. The highest of preterm is also in Africa. Africa, only after that comes India, among the Asian countries. So we find that it is on the increase, and the increase is because of the ART and the multiple pregnancies. That's why we find it's on the increase.
Madam, before going, what are the risk factors? See, for when you have, there should be why only few people go into preterm labor and others don't go into preterm labor. So what are the risk factors? We should be careful because we all want to prevent it. That is why.
See, actually, when you think of the risk factors, extremes of age are risk factors. That is all for us to see. Undernutrition, poor weight gain in pregnancy, low socioeconomic status, that all comes bunched up together as one cause. Then, as I told you, there's an ethnic difference, and I told you Africa, it's the highest, and Asia comes next. Then, actually, we see smoking. Now, let me tell you, we might think that our Indian women don't smoke, but even passive smokers are a problem. Do you understand? If you have got your dad who is smoking, then if you are pregnant, even you are liable to have the effects of smoking. We are all the people in the house are actually passive smokers. Then there is stress. stress, both psychological and physical stress. When you do hard manual labor, that is physical stress, and there is psychological stress. So all this actually, in a general format, this actually plays a very important as a risk factor for preterm labor. Then we have got something specific for the pregnancy, and that is when there are any developmental problems of the uterus. So like septate, biconvate uterus, they are more prone to develop preterm labor. And that is why we always, as we go by, we'll also be learning that we have taken the shortening of the cervix. That is a 10th centile shortening of the cervix. We take that so that we will know when these people have got that, are they prone to develop preterm labor? Then, of course, there are people who have got submucous fibroids and all the comorbidities associated with pregnancies. That also is a very, very important thing. Another one very important thing is previous history of a preterm birth. If she has had a previous history, she is very prone to develop preterm labor again. And as I told you all some time back, ARTs and the multiple pregnancies. Another one very important thing is any infection. See, you develop a diarrhea or you develop a gastroenteritis or you have typhoid or you have COVID, all are prone to any type of infection.
Madam, in this asymptomatic bacteriuria, they say
Yes,
that you have to be treated.
It has got to be treated. So much so, they say that this asymptomatic bacterium, if you will diagnose it only by a culture. And so it is necessary that you culture. And if you treat it, you're actually reducing the incidence of pyelonephritis, cystitis first and then pyelonephritis.
So, madam, is it a must that when you see pus cells or bacteria in urine as a routine, you have to do a culture as a routine?
Yeah, very good. See, it is important that, you may find because of contamination also, you may get a little bit of cells here and there. So if you've got a suspicion, do a culture. Only the culture will throw up, and that is what will throw up the asymptomatic bacteria, which should be treated. There's no question about it. Apart from that, even our pregnancy, other issues, pre-eclampsia, antepartum hemorrhage, all this adds on to the. So I would always tell my PGs, if someone asks you causes for preterm labor, whatever you say, you're right. Because everything will form one of the answers, right?
Madam, what about the chance of recurrence? Is there any specific, like one preterm, this much chance is previous history, two preterm, this much chance is there, something like that? Is there?
We say that recurrence of preterm births is 15 to 30% after one. Okay, so just say it's almost 1/3. So that is a phenomenal number for you to even imagine. So the more the number of preterm births, they say that after 2 preterm births, the increased incidence goes as far as 60%. And after 3, it is 75%.
Oh, 75%.
So when you think of that, it is a phenomenal number. Do you understand? So the previous history of a preterm birth is actually one which predisposes to another preterm birth. So beware. Okay, beware.
Okay, madam. So it's a very common problem, and that we all, and a severe problem. So can we predict this? We know the risk factors and all these things. Can we predict this preterm labor?
Yeah, that is a one very, very important thing. If you try to see the prediction, a prior history, that's very important, because I told you 15 to 30%, then I said after 2 to 60 and after 3 to 75. So prior history is very, very important. And then basically there are only 2 ways in which we can predict it. One is looking at the cervical length, and second is looking at fetal fibronectin. You would have heard about fetal fibronectin. Actually, it is a glue between the decidua and the membranes. So if you find in your cervicovaginal secretions, if you find fetal fibronectin positive, that means she is prone to develop a preterm labor in the next 7 days. So that is important. So only 2 things you can predict. That is, as I told you,
can we use it, fetal fibronectin as a screening test?
No,
can we use it?
Should not use it, okay? And I'll tell you one more thing. See, maybe in India we are not so strict about it, but abroad they will never treat. Just seeing a shortened cervix, they will not treat with tocolytics. They wait for a fetal fibronectin. Till that result comes, they will not give you a tocolytic, and if it comes positive, then they treat you.
Madam, if it is clinically established that preterm labor, then is there any need for fetal fibronectin?
Very good.
Is there
very
any
good
need?
Question, Aswath. See, I'll tell you one thing. When the dilatation is more than 3 centimeters, you don't even have to think. Just treat. You don't require a fetal fibronectin. But then that is a little too late. So when you get between 2 and 3, see, That is the temp between 2.5 to be more exact. Between 2.5 and 3, then for you to treat, it would be good if you have a fetal fibronectomy.
And
less than 2.5, we call it short.
Another question about fetal fibronectomy, usually they ask is that, is there any time limit? Like, see, it should be done only up to 34 weeks or 36 weeks, or no use of doing afterwards? Or...
when you take it too late, then it has no effect. It has no effect at all. So the earlier you do it, the better. More it has got its significance more in the early stage of pregnancy.
Is there any confusion with multiple pregnancy and all fetal fibronectomy?
No.
Nothing is there.
Nothing. No change.
So, madam, now coming back to the cervical length. Okay, madam, we want to know more about cervical length. How do you measure? How much you take? So many see less than how much is it, and like that. Is there anything?
Yeah, see, cervical length measurement is an extremely important thing. Okay, and the gold standard for that is a transvaginal ultrasound. You cannot be measuring.
That is what I usually ask in the exams for the PGs. That is the not transabdominal. It is the transvaginal ultrasound that we measure. Okay.
Yeah.
So what is the exact length? What now we say to less than?
Yeah. So actually, what you do is you will have to measure from the external os to the internal os. That is how you do it, and you must do a transvaginal ultrasound. And then you see three things. One is the dilatation. Okay. Then if it is dilated, they'll funneling, and then the cervical length. So there are three components which you should always look at. That is why there is actually an acronym which tells you trust your vaginal ultrasound. I don't know whether you all have heard it. That is a very good acronym for you to remember. See, when it is T is for trust. That means it's a closed internal os. When it is a Y, that means there is a little funneling, but there is a residual cervical length. V, it has come as far as the external os, but it is not opened. But then a U is the one that you really see a bulging bag of membranes. That is one. The second thing I want all of you all to remember is the time to measure the cervical.
That is what I was going to ask.
Yeah. See, the timing is very important. Don't, for heaven's sake, ask an 11 to 14 week scan. That is not the time to ask for it, okay? So the best time to look out for cervical length is between 16 and 24 weeks. Please remember this. And when you look at that, I told you some time back, they look at the less than the 10th centile, that is between 16 and 24 weeks. If the length is less than 25 millimeters of cervical length, that means it is a short cervix. Okay.
Madam, one more doubt is that do you have this? See, multiple pregnancies are there. What is the role of cervical length and in multiple pregnancy? It is a routine diagnostic criteria in preterm labor in multiple pregnancy.
Actually, it has no place. Let me tell you one thing as a logical thing also. See, when the uterus grows very big, there should be little leverage for the os to open. See, if the os is also very tight, then how can the uterus expand, freely expand? So actually you will see a little shortening, but there are people who have given even a shortening for multiple pregnancy. They have said that if it is less than 2 centimeters, or some of them have even said 1.5 as a cutoff for multiple pregnancy to say it's a short cervix. So when you say less than 1.5 also you're right. If you say less than 2 millimeters in multiple pregnancy also you're right. But in a singleton pregnancy between 16 and 24 weeks, less than 25 millimeters is a cutoff. Okay.
Cutoff. Okay. Madam, so coming to we told the predictors, we know that 2 predictors and all we told. Madam, coming to prevention. See, any prevention we can have primary prevention and secondary prevention. Coming to the prevention of preterm labor, how can you prevent?
See, let me tell you something. See, prevention, the primary prevention is you'll have to check the ARTs. Let them go for single embryo transfer. That's the only way to prevent it. Do you understand? Thereby we can reduce the multiples. Then, of course, you can check, reducing smoking and STDs and things like that. Any infection is a cause.
So, any risk factor, what we have told, can be controlled or we can prevent it.
That is primary prevention. But when you say about secondary prevention, there's nothing. You can correct any medical disorders. You can correct any small interventions like correction of any Mullerian malformation, especially a septate. I won't ask you to correct a biconvate, okay? Because biconvate, when you correct and you make it you have got more chance of a rupture as the pregnancy advances. So those are actually the secondary prevention.
Madam, is septum when you told, is it routine that you advise cervical cerclage Cerclage, if a septum is there, that's a question which is asked. Septum is corrected, and patient becoming pregnant, it's a routine to do a prophylactic Cerclage.
Yeah. See, about 20% of these patients with uterine abnormalities are prone to develop cervical incompetence. And when you say about a septum, even correction of a septum has been questioned. They say only if you got a recurrent pregnancy, loss only is an indication for us to correct the septum. Okay. But if there is a septum or a biconvate uterus, even if you put a Cerclage, I will say you're okay. Because that is one kind of prevention. They said only because I told you it's about 20% incidence. So it is as high as that. So there is no harm in actually doing it. Whether you have corrected the septum or not, it is good for you to put in a Cerclage.
Okay, madam. See, then now we come to the interventions of proven benefits. See, there are so many interventions which has been told during the years. So interventions of proven benefits, madam. Can you highlight?
Yeah, that is actually, it is a big question mark. And probably I can tell you there are 2-3 things which we can establish. One is, as Aswath was saying about bacterial vaginosis. You treat the bacterial vaginosis, it is proven benefit. There's no doubt about it. Asymptomatic bacteriuria, that is again definite proven benefit. But there are 2 queries all along. What is the place of progesterone? What is the place of a cervical Cerclage? Now, let me come to progesterone. Progesterone, basically, they say that as a routine, you don't have to give progesterone. Okay. We don't have to, because it doesn't prevent preterm labor either, unless the patient has had a history of prior, either it's a prior preterm birth or a prior second trimester loss. Okay, that is an indication for you to give the progesterone. Okay, that is one thing. Coming to cervical Cerclage also. Now, cervical Cerclage, just seeing a short cervix is not an indication for you to. When you just see a short cervix, please remember all what you need is you can start progesterones. But when you see a short cervix with the history of a preterm labor, that's an indication for you to put a Cerclage along with progesterones. Okay.
Okay.
That is very clear now. So a short cervix alone, it's only progesterone, and they have said vaginal progesterone, but dihydroprogesterone can also be given as an oral progesterone. But when you see a past history also, it's a definite indication for you to see that you put a Cerclage along with the progesterone.
Madam, coming to Cerclage, just for the PG sake, what is the timing, what you do, and what are the things about, some important points about Cerclage?
Yeah, very good. See, the time to put a Cerclage is actually between 13 and 23 weeks. Remember that, okay? Now, according to our thing, there are 3 types of Cerclages. One is a history indicated Cerclage, one is an ultrasound indicated Cerclage, and one is a physical examination indicated Cerclage. History, we already said. Okay, the prior history of preterm birth or a second trimester loss an indication. But let me tell you one advice, and that put that Cerclage early. That means soon after 12 weeks, around 13 weeks you can put it, 13, 14 weeks. So history indicated Cerclage is an indication for an early Cerclage. Okay. Second is an ultrasound indicated Cerclage. Ultrasound indicated Cerclage, I told you, trust your vaginal ultrasound. When you see it, you do it. That is your Cerclage at that time. But the physical examination, do you know what a physical examination indicated Cerclage is? That is, when I put a speculum, I see a bulging bag. That is a physical examination indicated Cerclage. That is also called an emergency Cerclage. That is also called a rescue Cerclage. Only for that, you can extend your time as far as 28 weeks. Okay, please remember that. So normally your Cerclage time is between 13 and 23 weeks, because that's a pre-viable state. Okay.
Okay.
So 13 to 23, easy to remember. But for the rescue Cerclage that is the old nomenclature, the physical examination indicated Cerclage, it is RCOG said up to 28 weeks you can extend it. And you can put your Cerclage.
Then another question they ask is that after doing a rescue Cerclage, what are the precautions you take, or what are the extra things, or if the patient, what are the things you... And one more thing, madam, I just want to ask you is that what is the role of bed rest in preterm labor?
Oh, very good, very good. See, I'll just tell you, there are many things which we should remember about. First is when you have to treat the patient with the preterm labor. A person who has got to be treated with a preterm labor, we do all what I told you, progesterones and the Cerclage, and I told you all that. But after the initial treatment, there is a lot of precautions you've got to take. The patient can be sent home. You understand? The patient can be sent home, and after that, we should not allow her to take bed rest. It's actually forbidden to take bed rest, because once you give the bed rest, what happens is she's prone to develop thromboembolic manifestations, etc. So it is important that they do not, but we always ask her to abstain from coitus, abstain from driving, abstain from, going to work. She can stay at home. She's got to keep away from her regular activities. But the most important thing is you will have to see to it that the important thing is that she stops working. She can stay at home, but no bed rest. And as I told you, I'll abstain from coitus, heavy work. She can walk about, do her small work, etc. All that is accepted, and she can continue her progesterones and take it on. Okay. Now that you say that, Aswath, I also want to say at this point of time one thing about the progesterone. There is something injectables. Yeah, I too thought I should say that. See, actually, injectable progesterones doesn't have a much of place in the first trimester, but from 16 to 36 weeks, if you have had a prior history of preterm labor, it is justifiable in starting injectable progesterone, which is 17 alpha hydroxyprogesterone caprate, given 250 milligrams weekly. You can start it as early as 16 weeks and you can carry it on as far as 36 weeks. It has found a place in the management and it is accepted.
Madam, anyway, you have told about progesterone. Can you just highlight, if possible, on optimum trial?
Okay.
Optimum trial, just vaginal progesterone with...
Yeah. Now I'll tell you, there are actually quite some trials. There is the Oracle trial, there is the optimum trial, and many things have come up. All of us might think that we have gained a lot from all these trials, but actually many a time they've added more confusion to our understanding of actually all these trials. Okay. Now, coming to the optimum trial and the Oracle trial, I wanted to tell you, before I came to the optimum trial, I wanted to tell you about the Oracle trial. Oracle trial 1 was actually done with premature rupture of membranes. It was done with preterm premature rupture of membranes, and they found that giving antibiotics helped. Okay, giving the antibiotics helped the patient. And they said that you could give the antibiotics in form of erythromycin. They also tried co-amoxiclav, and they said after that, don't give the co-amoxiclav because it is associated with necrotizing enterocolitis. So they can give erythromycin. I will tell you that as I come to the
management part.
But when it comes to the Oracle 2 trial, they said that in preterm labor they tried. That was with the intact membranes. The intact membranes, actually, they told us that antibiotics have got no place, absolutely no place. And so the place of antibiotics comes in only when you have got with the ruptured membranes or with the leaking membranes. Then that is the time that you give thing. Now coming to the trial which Aswath was asking me, that this optimum trial was actually a multicentric trial. That was a randomized double-blinded trial, vaginal progesterone for prophylaxis for preterm labor. And what they did was they gave the vaginal progesterone 200 milligrams daily from 24 to 34 weeks of gestation with the women with the risk of preterm labor. And their primary outcomes was they were looking at fetal death, fetal birth before 34 weeks. Ultimately, the interpretation was this, that vaginal progesterone was not associated with a low risk of preterm births or a composite neonatal adverse outcome in children. And so they found that there is no use of giving, it does not prevent preterm labor, one, just giving a vaginal progesterone. And second is, they also said that if given, there is no long-term adverse effects of giving a progesterone. That was another outcome. They tried as far as 2 years of age, they followed up these children in the optimum. And they said that there was no long-term harm or benefit by giving the progesterone. That was the outcome of the optimum.